Good morning, everyone. I'm Dr. Ashutosh, and my moderator is Dr. Ayushi ma'am. And today I'm going to present the topic EMDR, eye movement desensitization and reprocessing. So, what is it? It is a structured therapy that encourages patient to briefly focus on the trauma memory while simultaneously experiencing bilateral stimulation. That is typically with eye movements, which is associated with a reduction in the vividness and emotion associated with that trauma memory. It is a technique that has been used extensively and successfully in the treatment of post-traumatic stress disorder. Let's talk about history. The pioneering work on technique was conducted by Shapiro. Initially, technique was labeled as eye movement desensitization only. Later on, she refined the technique and renamed it as EMDR. Shapiro's method was introduced to behavior therapists by Joseph Wall in the annual meeting of Association for Advancement of Behavioral Therapy in 1990. Shabira proposed that in order to get relief from traumatic memories, the client must be aware of one or more of following. That is in an image of memory, a negative self-statement, the physical anxiety response. Effect is best when all of these three are combined, although presence of any of them would be sufficient for eye movement induced desensitization to occur. Let's talk about phases of EMDR. There are total 8 phases. First being comprehensive history taking and treatment planning, then preparation, then assessment, then desensitization, then installation, the body scan, then closure, and lastly the re-evaluation. History taking, there are three essential steps involved in history taking. That is identification of past memories, the present stimuli that trigger disturbance, skills, and behavior required for optimal functioning. Preparation. In the second phase, the client is prepared for the therapy. During this stage, he or she is explained the mechanisms by which EMDR work. Assessment at this stage, therapists identifies the traumatic incident to be reprocessed. The basic procedural elements may include a selection of images, negative and positive cognitions, emotions, and physical sensations. The anxiety levels concerning the incident is assessed by using Volpe's scale of subjective units of distress and a validity of cognition scale. Desensitization. The treatment is conducted in a place which should be free from distraction. A therapist ensures confidentiality of information provided by the client. For desensitization, the client is asked to follow the therapist finger movement usually while generating specific traumatic event. The therapist moves his finger back and forth rapidly and rhythmically within the visual field, approximately at 1 foot distance from the face for at least 12 cycles at the rate of 1 cycle per second across the visual field. The movement is repeated for 12 to 24 times for one set of second. This is bilateral stimulation by eyes. Uh, Next stage being installation increases connections to positive cognitive networks, enhance the validity of the desired positive belief, and fully integrate the positive effects within the memory network. The body scan, complete processing of any residual disturbance associated with the target, concentration on and processing of any residual physical sensations. Closure, ensure client stability at the completion of an EMDR session and between the sessions. Briefing regarding expectations and behavioral reports between sessions. Reevaluation, ensure maintenance of therapeutic outcomes and stability of client. Evaluation of treatment effects. Evaluation of integration within the larger social system. It is also used in other conditions apart from PTSD, that is bipolar disorder, unipolar depression, depression after MI, panic disorder with agoraphobia, substance use disorder, and chronic back pain. Thank you.
Good morning, everyone. My topic is token therapy. My moderator is Dr. Sagar. Token economy is a behavioral intervention that uses tokens as a reward for desired behavior. It is based on the principle of operant conditioning and can be used to shape and reinforce positive behaviors. So token economy is a method used for learn from the learning approach to improve behaviors. It is commonly used in prisons and young offenders institutions. A set of desired behaviors are set up by the staff. When these are followed, the patients are rewarded with a token. This is a secondary reinforcer. Tokens can be saved up and then exchanged from something of the value of the prisons. For example, extra time, TV time, or chocolate. These are the primary reinforcers. The tokens can then become reinforcers for the good behavior. Token economy, the learning approach. Token economy is a treatment method based on operant conditioning. It teaches the participants to unlearn abnormal behavior and learn normal ones. So this is the cycle. The child has no tokens, no access to desirable items or activities. Then child engages in a desirable behavior or target behavior. Then child is given tokens for engaging in these target behaviors. Child trade their tokens for the access of desirable items or activities. Token economies, tokens, these are conditioned reinforcers that can be accumulated and exchanged for backup reinforcers. Backup reinforcer, a stimulus that causes others to become a conditioned reinforcer when they are paired with it and used to establish and strengthen the condition. These are the seven elements of token economy. First, target behavior. Select the desired target behavior to be strengthened. Second, type of token. The token can be used as conditioned reinforcers, for example, poker chips, star stickers, etc. Backup reinforcer. The backup reinforcer to be exchanged for tokens, for example, sweets, free time, etc. Reinforcement schedule. A reinforcement schedule for token delivery. Exchange criterion, how many tokens are needed to be exchanged for the backup reinforcer, time, place for exchange, a time and place for exchanging tokens for the backup reinforcer, response cost, a penalty or a fine when tokens are taken away from engaging in inappropriate behaviors. Challenges and consideration. Implementing a token economy requires careful planning, consistent monitoring, and individualized reinforcement schedules. Challenges may arise in maintaining motivation and addressing individual needs. It is important to consider ethical implication and ensure fairness in token distribution. What are the advantages? When it can be given immediately after desirable behavior and cashed in later for backup reinforcers. Bridge the delay. Second, token can be generalized reinforcers. For example, paired with many different backup reinforcers. What are the disadvantages? It may be incentive to incentivize to unethical behavior such as stealing tokens or sabotage by participants. Participants can become dependent on it. Withdrawal of tokens may result in decreased desirable behavior or increased bad behavior. Philosophical opposition to token reinforcement as it constitutes bribery or blackmail. In education settings, token economy raises the question of whether it undermines intrinsic motivation as a result of over justification effects.
Morning, everyone.
My topic is today Lurasidone. Myself, Dr. Ayush, and my moderator is Dr. Vishnu. What is Lurasidone? It is a newer second generation atypical antipsychotic, belongs to chemical class of benzoisothiazole derivatives, and it was approved by US Food and Drug Administration for schizophrenia and bipolar depression in 2010 and 13 respectively. It was the first drug approved both as a monotherapy and as an adjunctive to lithium or valproate. Its pharmacological properties. It is available as from 20 mg strength to 20 mg strength. It reaches peak serum concentration in approx 1 to 3 hours and steady state concentration in 7 days. It has mean half-life of 18 hours when seen in 40 mg strength. It is metabolized in liver by CYP3A4 enzyme system, so caution is necessary when administered with strong CYP3A4 inducers or inhibitors like rifampin and ketoconazole respectively. It should be administered after a meal of at least 350 calories as it increases its absorption. Recommended starting dose for schizophrenia is 40 mg with a maximum dose of 160 mg per day in adults, whereas 80 mg per day in adolescents. Recommended starting dose for bipolar depression is 20 mg per day with maximum dose of 120 mg per day in adults and 80 mg per day in pediatric patients. However, patients with moderate to severe renal and hepatic impairment will require dose adjustment to no greater than 40 mg per day. Its uses and advantages. Lurasidone is used in patients of schizophrenia and bipolar depression only. Lurasidone offers a safety advantage when compared with some other antipsychotic agents. It has less risk of metabolic side effects like hypercholesterolemia, hyperlipidemia, hypoglycemia, and weight gain as compared to other atypical antipsychotics like risperidone, quetiapine, and olanzapine. It is associated with good cardiovascular tolerability with lesser QTc prolongation. It has least cognitive and memory deficit due to lack of anticholinergic effect, and it has lesser chances of relapse. Its adverse effects: somnolence, akathisia, nausea, Parkinsonism, and agitation. In schizophrenia, common side effects are nausea, akathisia, Parkinsonism, somnolence, and sedation. What is used in schizophrenia? Medication. Yes, ma'am. Yes, ma'am. In schizophrenia, side effects. थोड़ा सा चेंज है बाइपोलर डिप्रेशन में थोड़े ज्यादा एक्सेप्टेबल साइड इफेक्ट्स long term use of lurasidone also showed modest weight gain. Several short-term clinical trials observed significant increase in prolactin levels. Lurasidone, when used in pregnant patients, may cause extrapyramidal or withdrawal syndrome in neonates when exposed in third trimester. These are few side effects. The comparison between lurasidone and other antipsychotic agents. Contraindications. When used concomitantly with moderate CYP3A4 inhibitors, it is recommended to decrease the lurasidone dose to half of the original level with a starting dose of 20 mg per day and a maximum dose of 80 mg per day. Similarly, when combined with moderate CYP3A4 inducers, the lurasidone dose may be increased appropriately. Examples of CYP3A4 inhibitors are clarithromycin, ritonavir, indinavir, ketoconazole, etc. The examples of CYP3A4 inducers are rifampin, phenytoin, carbamazepine, modafinil, armodafinil. These are my references.